an original.
From Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. So in our last episode, we spoke to Dr. Martin Gibala about high-intensity interval training, which he called SNACs, so short burst training. Lots of great information, and if you missed this episode, you can listen to it on our Spotify and Apple feed. And if you want to receive notifications for the most up-to-date episodes, subscribe to this show. Today I'm joined by Dr. Ashwin Juneja, who will discuss pharmacogenetics and how it can help people ensure they get the correct medications to help them with their chronic pain or other health conditions. Ashwin, welcome to the show.
Thank you very much. Pleasure to be here.
Great to have you on. I know we talked offline a little bit about this, so I'm very interested in what this is all about. Let's just start from the top. What are we exactly talking about that can help people with their pain? And I guess matching medication is what we're looking at here. Is that correct?
Yeah, it's kind of a decision aid that helps to fill out the puzzle. You know, we look at many different factors when treating individuals, but genetics tends to be something that hasn't quite been integrated yet. So we kind of view this as a missing link. And essentially what it is doing is looking at an individual's genetics and seeing how that links to the way a medication can work. Some individuals may have specific variations in their genes that predispose them to, for example, processing a medication too slowly. And that's why, or that might be a contributing factor to why they're having side effects, or they might process it too quickly, and that might be a reason why the medication isn't working. So it's another piece that really is emerging and can really provide some quality, useful insights in terms of helping not only manage pain, but really helping people to function better and support an improved quality of life.
And how long is this, when did this really start? Has it been around for a while? Is this something new?
So I think in the last couple of decades, maybe 10, 15 years, we've really seen an acceleration in the discovery and adoption. Prior to that, it's sort of been in the background, maybe a niche area that hasn't been quite ready for prime time. When I did my bachelor's degree in pharmacy, so this was in the mid 2000s, it was mentioned once.
Oh, really?
Yeah. And it wasn't really even the underlying scientific and clinical basis. It was more about, this is what it is. When do you, let's sort of share opinions on when we think this might become a major part of care. So really in more recent times, we've seen an increase in the number of publications coming out, discovery researchers, and that ending up trickling into changes in practice or sort of discoveries that can be implemented into clinical practice.
So I guess I'll have two questions. We'll start off with one is what kind of research has been done on this? How does it look at genetics tied to medication? How is that whole process done? And what are some of the outcomes of the research?
It's a pretty complex question because there's a lot of different pieces to it. So, oftentimes there's this saying bed to bedside in terms of life sciences research. And when we look at genetics, it's no exception in the sense that, there's the aspect where researchers are looking to discover and really categorize specific variations in genes. Some are actually not known very well, or we just don't know what they do. And then what that actually means in terms of impacting the functioning of the protein in the body that is responsible for interacting with medication. And then, if that actually has a meaningful difference in terms of the way an individual feels or experiences that medication, there may be an interaction there, but may not be enough to actually change things. Or there might be other systems in the body that actually offset or mitigate some sort of deficiency. And then, then we look into things like, okay, does this impact blood levels of the medication? Because we know that, for many medications, blood levels will link to those outcomes we're talking about. And then, next level is actual differences in the way individuals feel. So those specific side effects or effectiveness. could actually be a lab value, so cholesterol or another marker that we're looking to treat. And then um, lastly, then we look at things like heart attacks or mortality. Um, I suppose maybe one other aspect of that would be the cost aspect, and looking to see, you know, these results, how do they actually translate into healthcare resource utilization? So the costs on the healthcare system because of this test, does it save money? Does it improve outcomes but not actually save money? Does it cost more money than just using standard approaches? It's more on the former side, whereby it actually saves costs. But that's sort of the overview of the research that's been looked at. And there's research through all of those domains. There's also, of course, qualitative research as well, like satisfaction surveys and things like that, in terms of the healthcare providers, their patients, et cetera. We're looking at all of that, and there's evidence across that spectrum. For example, when we have a good idea that the medication's blood levels has a really strong impact on how the medication works, and if we've seen that trend multiple times, that actually might be give us enough rationale to say, hey, we should look at this. Ideally, of course, we'll look for things like, an individual didn't have, like, less individuals had this side effect, or more individuals, had an improved outcome, say a cardiovascular outcome, because we selected their medications based on their genetics. But yeah, it's a kind of a pretty broad piece, and I know it's complex. I hope I simplified it at least a little bit, but hopefully I've answered that part of the question.
So if I understand you correctly, if someone were to take a medication, um, what's the one that's controversial out there? I guess statins would be one, right? For example,
Yeah.
there's so much on that. So you could measure that if someone's taken that you talked about blood level. So what the effect of that is inside their blood, in a sense, right? Like how it's impacting. Is it actually working to reduce LDL buildup, or so is that what you're talking about in a sense when you're looking at? I'm trying to simplify it for our audience a little bit.
No, it's 100%. It's a great example because of, everyone and their brother is on one. We know these medications have a very well established role. Some people, feel strongly one way or another about that, but I won't get into that because it's not the main
Yeah.
topics of the day. So essentially, when it comes to statins, the key thing we're looking at from a genetics perspective, which is quite apropos for today, is their link to muscle aches and pains, a weakness, which is, of course, a quite commonly reported side effect. And this is often due to a number of reasons. This can be due to thyroid function, kidney function, but it also seems to be related to variations in certain genes. And certain statins seem to be better, certain ones seem to be worse when it comes to the genetic impact, variations in specific genes and their propensity or their likelihood of having those muscle related side effects. And some of the data will look at, okay, well, this medication, because of this variant, blood levels are higher of this medication. So this is actually part of the rationale, because we know that higher blood levels can cause this, because when you look at the basic fundamental pharmacology of statins, just on a basic level, essentially it's going into the liver, and it's going to the liver to help reduce bad cholesterol and change sort of cholesterol parameters. But if the medication can't get into the liver very well, it's going to go to the rest of the body, and it's going to go into your muscles, and it's going to perhaps increase your risk of those side effects. And so to get into the liver, to get into the cells of the liver, you need certain proteins that shuttle them in. They're like basically almost like a bodyguard or a bouncer saying you can come in, you stay out. And if that's dysfunctional and it's, say, not letting the statin in, it's looking for other places to go in the body. And once it goes to those places, because that variant didn't let them in, those side effects are more likely to occur.
So then by doing the genetic testing, you could say, well, this variant of the statin will not work. However, this one would work and allow, like you said, to get into the liver and do what it needs to do versus going to other areas of the body. Is that correct?
Yeah, you have to look at with in conjunction with those clinical factors as
Right.
well. But it's one more piece that can glean some really important insights. And I think it's not just going forward saying, I need a statin. Where do we go from here? But it's also, oh, I've tried a statin and I really didn't like it, but I need to take a statin because I'm at high risk for a stroke or a heart attack. Where to now? Or, was it maybe due to my genetics? And so now where to? So looking sort of into the past to see what happened and seeing if it aligns with genetics can actually be quite positive and helpful, and not in terms of now going forward saying, okay, maybe this is the right option, but it's also very validating for an individual to see that because individuals, unfortunately, sometimes individuals' complaints are dismissed. It's all in your head. Well,
Mhm.
maybe it's not all in our head. Maybe it's in our genes.
And would the same be like, I mean, we just use statin as an example, but there's lots of medications out there. From my understanding, my limited understanding too, is medications could have adverse effects on organs as well too, depending on an individual. Is that correct?
Certainly, medications can have an adverse impact on organs. Pharmacogenetics may have a role there. There's probably not a really great. I don't really have a great example off the top of my head.
Okay.
Um,
Because I know you'd mentioned how I was just picking up on you were talking about kidney function and how that can different medications could impact that. So that's one of the reasons I brought it up. So I
yeah,
was thinking if somebody went through this process, would that also help versus going through and trying something and then having severe side effects and then going back and trying another brand? And would this help limit that kind of trial and error process?
it's probably more of a complementary aspect in the sense that when you're getting rid of medications, it's usually going through the liver and then through the intestines, or going through the kidneys and you're peeing it out, or a combination of the two. And so, if you're impaired genetically in your liver, and then it has to go through the kidneys. So if you have poor kidney function due to some unfortunate medical events in your life, and then you have this genetic predisposition in the liver, and you're taking this medication, okay, well, maybe the genetics as it relates to what's happening in your liver will say you're at increased risk for this side effect. But then now if we add on that poor kidney function, maybe your risk is actually now even higher. And that's sort of that clinical puzzle decision making judgment that the healthcare provider or clinician sort of would hopefully take into account.
And so that what you're doing with the work you're doing, that kind of helps prevent that in a sense. Am I saying that correctly or?
Well, it's another piece. So when you look at use of medications, appropriateness, there's all sorts of factors, and each drug has specific factors. So some medications, their effect may be different in somebody who has more body fat versus somebody who has less. If you were born as with a biological sex of being a female versus a male, for example, you may be more predisposed. Your kidney function, your liver function, if you've had bariatric surgery, that can impact absorption of a medication, the underlying disease, and then interactions with other medications. If you've had reductions in your liver function, all these factors can be implicated, plus more. And so really it's about then taking the genetic factor and plugging that into the as other known factors to fill out that picture, really, so that we have a more complete understanding, so we can kind of get to a better choice um, sort of sooner, um, and hopefully in some cases there are some catastrophic events associated with certain genetic variations. So avoid some of those catastrophic events. So, you may be avoiding a stomach ache, but you also may be avoiding, in other cases, a life threatening rash, for example.
So it's basically a piece of the puzzle. So you have all your other clinical items that are going on, and this just kind of complements that versus the going into the trial and error and seeing what's working.
Yeah, it's not meant to replace anything. It really is there to complement. It's an incremental gain that has important considerations and impacts that unfortunately hasn't quite made it in to most domains yet.
So I guess then the other one would be, how does somebody go about getting this? So if we go through a patient's, I guess, journey, they go see their doctor, say they got chronic pain or some other health issues, and they need medication. So is this something that would be provided or referred through an MD, or is it something that the
Yeah.
person has to seek out on their own?
There's a few specific cases where genetic testing is embedded into the prescribing process, but those are more few and far between, and those generally don't really impact chronic pain management. So for the most part, really, the uptake is driven by the individual being treated themselves. So unfortunately, an individual has to have some awareness for the most part because it hasn't hit mainstream practice yet. But on the other hand, the barriers to access the testing um, are maybe less significant, though they can still be significant for some individuals. So in Canada, you can simply order the tests online through the lab provider. For example, our company, many individuals go onto our website and purchase the test, and then they'll actually get the test mailed to them. So it's essentially just a really easy cheek swab. They swab their own cheek, pop it into the little tube and into the mailer, and it goes to our lab, and then we analyze it, and then the results are posted in a secure portal online, which they have to register for. Um, but of course, they have to have the funds to pay for it, or the insurance to reimburse them for that. So that's sort of one barrier to consider. But generally speaking, it is pretty straightforward to actually get testing done. And that's how the majority of individuals are accessing it, I would say, at this time, based on what I've seen.
And once they do that, what does the report actually tell a person? Like,
Yeah.
a lay person, for example, who may not have no medical background, are they taking this to their family practitioner, to the specialist to look at, or to their pharmacy? Like, how does this all work with the report?
The healthcare provider has to be in the room to extract the value of that testing because it's them, obviously, that are prescribing or influencing the treatments being made. Um, no doubt with influence from the input of the individual being treated. So when they actually get the results, what we're doing is we're matching the variant that we've detected, or the variations that we may have detected, or we may not actually see it, and say, actually, sorry, let me back up. um, so what we're doing is when the results are tested in the lab, we're looking for specific variations. And then when we see those variations, we're mapping the presence of those variations to what scientific guidelines or pharmaceutical manufacturer guidance says is the impact um, of the medication in those with those types of variations. And in many cases, they'll have very specific guidance as it relates to that. So this may include an adjusted dose or adjusted dose frequency, um, a changed a follow up and monitoring um, uh, protocol. So maybe we need to use maybe we need to make dose changes more slowly compared to um, most individuals. It may suggest that you're more predisposed to a side effect. It may suggest that you may have lower likelihood of effectiveness. It may say, hey, maybe we actually need to do a non-genetic test to look into this further. Or, in some cases, the data we may have may simply suggest that you have increased exposure of the medication in your body. So it can give you an insight that is attached to a tangible adjustment consideration, or it could be more general in nature. And so that is written in as plain text as we can to support understanding of the individual being tested, but it's also written in a way that's robust, such that the healthcare provider can then interpret that and consider that within the treatment decisions. That can be a family doctor, a specialist, pharmacist, nurse practitioner, dentist, really depending, of course, on the areas and the medications that are relevant to their practice and what they're treating.
When we look at that report, so for example, if we pick a medication, let's pick the statin again, I guess. So
Sure.
are you listing the effects for each medication that's out there, or is it rated towards the person illness and medication they would take for that illness?
So we're not collecting unnecessary data. There are limitations to what we're reporting. And then the other part of it is that we're only reporting those medications with associations that have a minimum strength of data. So that's repeat findings in multiple studies reviewed by expert groups that grade the data, that sort of thing. So if a medication doesn't have strong enough genetic associations, it simply just doesn't make it onto our tests. Some
Okay.
individuals, of course, would love to see, X medication on there, but it's not there for a reason. And, it could be that insufficient study has occurred. So maybe there is an association in the wings that hasn't been fully examined. But it also could be that the medication is robust enough that its general impacts, its known impacts in terms of effectiveness and tolerability, um, sort of apply towards a large range of individuals with a large range of genetic variation. So the variations that individuals have don't seem to have a meaningful impact on how they respond to the medication. And this can be because evolutionarily the genes just didn't go in too many directions, because the medication, if they did, individuals would have perished. So they didn't survive to pass on their genes. And then in other cases, it could be that we just have backup mechanisms in our system. So a lot of medications go through our liver to be processed through a sort of a super family of genes. And a lot of these will cover one another. So if one is deficient here, we know that this medication is sort of metabolized in part by, say, three enzymes that are genetically determined, and one is really deficient. The other two will sort of say, okay, we got this. We have the extra capacity. We can take this on. So those are some considerations. So really, it's not the entire universe of medications. It is a limited number. There are some very common medications in there, and there's some very common medications that don't have genetic associations. And over time, maybe we will see some insights that can be usable, but in other cases, perhaps we won't.
Perfect. So is this in Canada? I mean, your company in that, is it approved by Health Canada?
Our swab is approved by Health Canada, so there is no formal regulatory framework for pharmacogenetic testing in Canada. So what we do is we're just proactive about it. We subscribe to U.S. Regulatory bodies for quality control and quality assurance, and I think some other labs in Canada do that too, and then some ISO. We have an ISO certification as well. So we're mostly looking towards international standards um, to sort of demonstrate the quality that we're ensuring. But there's really not much of a framework through Health Canada for pharmacogenetic testing.
Well, hopefully that'll change in the future. Very interesting topic, and probably could talk a lot more trying to understand it. We'll have your company name in the link below in the details and that, but I really appreciate you being on the show today, Ashwin. I'm sure this will help a lot of people just kind of understand what's out there. I mean, it's the first I ever heard of it, so it's interesting.
Very much my pleasure. I hope I didn't talk too much.
No, not at all. Not at all. I think it's obviously quite a lot to this topic, so no, not at all.
100%. I really did enjoy it, and I thank you once again for inviting me.
Well, great to have you on the show. And for our audience, for feedback about the show or more information on chronic pain, you can visit our website, veteranschronicpain.ca, or follow us on Facebook and X at Chronic Pain COE, and on Instagram at chronicpain_COE. Stay safe and keep the hope alive.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network.